Welcome back to the deep dive.
Yeah.
You know, we spend a lot of time looking at the different components of the human machine in our source material, like the pump that is the heart, or the bellows that are the lungs, the filtration plant of the kidneys.
Right, the plumbing and the mechanics.
Exactly. But today,
Yeah.
we are going upstairs to the CEO's office.
The mainframe.
Yeah, the mainframe. We are tackling the system that arguably defines who you are more than any other system in your body. We're getting into the wiring, the processor, the sensors.
The neurological and sensorineural systems.
Right. And honestly, looking at the stack of research and the notes we have today, the vibe it's just different.
It really is.
Because with other body systems, you often have a bit of a grace period, you know?
Oh, absolutely.
If your kidneys start acting up, you usually have some time, days, maybe even weeks to figure it out before total failure. But the nervous system...
It demands immediate attention. It really does.
Yeah, that's the thing that kept jumping out at me from the sources. There's this recurring motif, almost like a warning siren in the text.
Time equals brain.
Time equals brain.
Yes. It is the golden rule of neurology. It's the absolute foundation of everything we're going to discuss today. Because unlike the liver or your skeletal muscles, the brain has, well, it has zero storage capacity.
Not at all.
Literally none. It cannot store oxygen, and it cannot store glucose. It runs completely in real time.
It's living paycheck to paycheck.
That is a perfect way to put it. So if the supply line is cut, if that blood flow stops for any reason, the damage starts almost instantly. Minutes matter. Sometimes, honestly, seconds matter.
That is a terrifying thought.
It is.
But I think it also gives us a very clear mission for this deep dive. Because we need to understand how to keep that system running, and conversely, how you can spot when it's about to crash.
Right.
And looking at the framework from our source material, it seems like the nervous system, despite all its incredible complexity...
The billions of neurons and synapses.
Yeah, all of that. It really boils down to four main needs.
It does. If you strip away the complex Latin names for a moment, the brain is an engine that just needs four things to survive. First is perfusion.
Which is blood flow.
Right, blood flow. Second is oxygenation, because the blood actually has to carry oxygen, obviously.
Right, pumping empty blood doesn't help.
Exactly. Third is glucose. It needs fuel to burn. And fourth is electrical conduction.
The wiring.
The wires have to be intact to actually send the signal.
Okay, so perfusion, oxygen, glucose, electricity. P-O-G-E, POGE.
POGE?
I don't know if that's a great acronym, but let's stick with it.
It works for me. And here's the key takeaway from the sources. If you disrupt any one of those...
Just one.
Just one. If blood flow stops, if oxygen levels drop, if sugar bottoms out, or if the electrical signals go haywire, you have a neurological emergency.
Wow. And I love how you framed this before we started recording today. You mentioned that we're going to look at everything today, from trauma to tumors to strokes, but through a very specific lens of priorities. Because this field is so vast, you can't just memorize lists of symptoms.
No, you drown in the information. You have to understand the strategy.
So what is that strategy?
The lens is preventing secondary injury.
Okay, define that for me.
Well, primary injury is the event itself, the car crash, the stroke, the baseball bat to the head.
The thing that already happened.
Right. We can't undo that. That specific damage is done. But secondary injury is what happens in the minutes and hours after that event. It's the swelling, it's the lack of blood flow, the hypoxia. That secondary wave is what kills the neurons that actually survived the initial impact.
So our entire medical strategy is to intervene effectively to stop that secondary wave of destruction.
Exactly. It's a rescue mission for the surviving brain tissue.
Okay, so we are on a rescue mission. Let's start in the engine room, as it were. Segment 1.
Let's do it.
We need to talk about the physics of the skull because it's completely unique in the body.
It is. It's a rigid box.
A closed box.
Right. It's a fortress designed to protect the very soft, delicate tissue inside. But that incredible strength is also its greatest weakness during an injury.
It can't expand.
Exactly. If your arm swells, the skin stretches. If your brain swells, it hits bone. So we have to talk about cerebral perfusion pressure, CPP.
The math of keeping the brain alive.
Yes. This is crucial.
I saw the formula in the notes. CPP equals MAP minus ICP.
Right.
Now, for the listener who might be having traumatic flashbacks to high school algebra right now, let's unpack that.
I promise it's simpler than it sounds. Think of it like this. Imagine you are trying to water a garden that is inside a sealed pressure cooker.
Okay, a garden in a pressure cooker. Got it.
The garden is your brain tissue. The water pressure in the hose coming from the house, that's your MAP, arterial pressure.
So that's the force your heart is using to push blood up against gravity into the head.
Exactly. MAP is the push from the heart.
Okay.
But inside that pressure cooker, there is already pressure pushing back against that hose.
And that's the ICP.
Intracranial pressure, yes. So CPP, the cerebral perfusion pressure, is the net amount of blood that actually makes it into the brain tissue to water the garden.
Ah, so it's the push from the heart minus the resistance from the skull.
Precisely.
That makes total sense.
Yeah.
So for the brain to get fed, the heart's push has to be stronger than the skull's resistance.
Always. And here's where it gets incredibly dangerous. This is the mechanism of the vicious cycle mentioned in the literature.
Okay, walk me through the cycle.
Imagine a patient gets hit in the head. The brain tissue gets bruised and it starts to swell.
So the pressure inside the skull, the ICP, goes up.
Right. The resistance rises. And because the resistance is higher, less blood can push its way in. So your CPP drops.
The brain is getting less blood.
Exactly. Now the brain tissue is starving. It becomes ischemic. And what does injured, starving tissue do?
It swells even more, like a sprained ankle.
It's edema, yes. So the new swelling increases the pressure even more, which decreases the blood flow even more, which causes more swelling.
Oh, wow. It's a feedback loop from hell.
It really is. If you don't break that cycle medically, the pressure inside the skull eventually equals the pressure coming from the heart.
And flow just stops.
Flow stops, and that is brain death.
That is incredibly stark. It explains why neurocare is so utterly obsessed with managing pressure.
You have to be.
Now, usually, the body has a way to handle everyday changes in pressure, right? It's called autoregulation.
Right. In a healthy, intact brain, the blood vessels are really smart. If your blood pressure spikes because you ran up a flight of stairs or got scared, the brain actually constricts its vessels to keep the flow steady.
So your brain doesn't just get blasted with a fire hose of blood.
Exactly. And conversely, if your blood pressure drops, the vessels dilate, they open wide to scoop up every available drop of blood. It protects the brain from those normal daily swings.
But I am sensing a but here.
But trauma breaks the thermostat. If you have a massive traumatic brain injury, a TBI, or a major stroke, that autoregulation mechanism can completely fail. The brain loses its shock absorbers.
Well, what happens then?
Suddenly, the blood flow to the brain becomes dependent entirely on your systemic blood pressure.
Which means if your overall blood pressure drops, the brain starves immediately.
Yes. That is why, in a neurotrauma patient, hypotension, low blood pressure is the absolute enemy.
Because it triggers that secondary injury we talked about.
Exactly. You have to keep the systemic pressure up to force blood into that swollen box.
Okay, before we leave the anatomy lab and get into the actual trauma bay, let's talk about how the brain is organized.
Good idea.
Because the sources emphasize that knowing the layout helps us play detective later. We have this concept of lateralization.
The left versus right brain.
Right.
So for the vast majority of people, about 95% of right-handed individuals, the left hemisphere is the analyst.
The analyst, okay.
It handles logic, math, and crucially, language. It's where you process and produce speech, and it also controls the motor function on the right side of the body.
Because the wires cross over in the brainstem.
Exactly. They crisscross.
So if I have a stroke on the left side of my brain, I'm likely to have trouble speaking, and my right arm might be weak.
Correct. That is the classic left brain stroke presentation. Now, the right hemisphere is the artist.
Okay, so it handles different things.
Very different. It's about spatial awareness, attention, recognizing faces, music, and emotion. And of course, it controls the left side of the body.
Right.
Now, here is where it gets really weird, and the sources highlight this. A right-sided stroke might leave a person's speech perfectly intact.
So they can talk to you just fine.
They can hold a normal conversation, but they might develop something called neglect.
Neglect. What does that mean in this context?
Unilateral neglect. They literally stop acknowledging that the left side of the world exists.
Wait, like a blind spot?
Worse than a blind spot. It's an attention deficit. They will eat only the food on the right side of their plate. They will shave only the right side of their face.
You're kidding.
I'm serious. You can stand right next to them on their left side and scream their name, and they won't turn to look at you because, to their brain, that physical space simply isn't there anymore.
That is mind-blowing. It really shows how our entire reality is just a construct of these neurons firing correctly.
It's very humbling to witness.
And running underneath all of this higher-level processing are the cables. The cranial nerves.
The vital connections, there are 12 pairs of them. But for a quick assessment, what we call the primary survey, we really care about the ones that tell us if the brainstem is working.
Because the brainstem is what keeps you alive, right?
It's the lizard brain. It runs the autopilot. Breathing, heart rate, so we check specific cables. Can you move your eyes?
That's a test?
Yeah, that involves cranial nerves 3, 4, and 6. Then we look at the face. Is your face symmetrical when you smile? That's nerve 7.
Okay.
Can you swallow? Do you have gag reflex? That's nerves 9 and 10.
So if those specific cables are cut or compressed, it tells you the damage is incredibly deep and the patient is in immediate danger.
Exactly. If you lose your gag reflex, you can't protect your airway from your own saliva or vomit. That is a critical, life-threatening finding.
Wow. Okay, that perfectly transitions us to segment 2, detective work, assessment and diagnostics.
The most important part of neurocare.
Right. So you walk into a room, you see a patient. How do you know before they literally code that something is wrong? The sources outline a primary survey.
It follows the standard ABCs that everyone knows: airway, breathing, circulation, but with a very specific neuro twist.
How so?
Well, airway isn't just asking, is the tube open? We are asking, can the patient protect it?
Like the gag reflex you just mentioned.
Exactly. If they vomit, are they going to choke and aspirate? If the answer is yes, we don't wait, we have to intubate, we take over the airway for them.
Okay, then breathing.
Again, the brainstem controls the respiratory rhythm. If you see irregular breathing patterns like Cheyne-Stokes respiration,
What does that look like?
it's a pattern where they breathe really fast and deep, then the breaths get shallower, and then they completely start breathing for 10 or 15 seconds.
Oh, wow. An apnea pause.
Yes. And then they start breathing fast again. If you see that, it is a blaring siren going off. It means the brainstem is actively being squeezed.
And circulation we kind of touched on. You have to keep the MAP up to fight the ICP.
Keep the pressure up, exactly.
But the notes strongly highlight that the single most sensitive tool you have in your assessment arsenal isn't a machine or a monitor.
No, it's not.
It's LOC, level of consciousness.
It beats the machines every single time. Long before the blood pressure drops, long before the pupils blow, the patient's level of consciousness will shift.
And the sources say it's subtle. It's not just someone passing out.
It's very subtle. It might just be restlessness.
Restlessness. Just fidgeting.
Yeah. A patient who was perfectly calm an hour ago is suddenly picking at their bed sheets. Or they keep trying to get out of bed for no reason.
Or confusion, I imagine.
Right. Maybe they know their name, but they think it's 1995. Or they answer your questions, but they are just a little harder to wake up than they were during the last check.
Just a little more sluggish.
That subtle drift, that tiny change in personality or wakefulness, that is the brain running out of oxygen.
So if you're watching someone after a head injury, let's say a kid who fell off his bike and hit his head.
Good example.
You're really watching for that personality shift or that mental fog rolling in. You're not waiting for them to collapse.
Do not wait for them to go unresponsive. That is way too late.
Now, if you do miss those early signs or if the injury is just too massive, you start seeing the late signs.
The body's absolute last-ditch effort to save the brain.
The Cushing triad.
Yes.
This is when things are critical. What are the 3 signs of the triad?
Well, remember the pressure cooker analogy?
Yeah, the brain's starving because the resistance is too high.
Exactly. The brain is literally starving for oxygen. So it screams down to the heart, I need more pressure to get blood up here.
So the heart pumps harder.
The heart responds massively. You get severe hypertension, very high blood pressure, but specifically with a widening pulse pressure.
Widening pulse pressure, meaning the gap between the top number and bottom number gets bigger.
Yes. The systolic, the top number, shoots way up, but the diastolic stays the same or drops. So you might see a blood pressure of 200/70.
Wow. Okay, so that's sign 1. Massive pressure.
Then the body's pressure sensors, the baroreceptors in the neck, they sense this massive spike and they say, whoa, heart, you are pumping way too hard. You're going to blow a vessel.
So they try to slow it down.
They send a vagus nerve signal to slam the brakes on the heart rate. So you get sign 2, bradycardia, a very slow pounding heart rate.
Okay, so high blood pressure, slow heart rate.
And sign 3 is those irregular respirations we mentioned earlier, the Cheyne-Stokes breathing.
High BP, slow heart rate, weird breathing. That's the triad.
That is Cushing triad. And if you see it, it means brain herniation is imminent. The brain is about to be physically pushed out at the bottom of the skull. It is a run, don't walk situation.
That is terrifying.
Yeah.
What about the eyes? Because every medical movie shows the doctor shining a pen light into the patient's eyes.
Checking the pupils.
Yeah.
Yes, we look for size, equality, and reactivity.
Reactivity meaning how they respond to the light.
Right. We want them brisk. If you shine a light in an eye, the pupil should shrink down immediately.
But what if they don't? The phrase in the notes is fixed and dilated.
If one pupil becomes fixed and dilated, meaning it gets huge and it does not shrink when you hit it with light, that is a very ominous sign.
Why does that specific thing happen?
It's mechanical. As the brain swells and starts to herniate downwards, the temporal lobe of the brain physically pushes down and pinches the oculomotor nerve.
Cranial nerve 3.
Yes, it pinches it against the hard ridge of the skull. It's exactly like stepping on a garden hose. The signal is cut off and the pupil loses its tone and blows wide open.
That phrase, fixed and dilated, always sends a chill down my spine.
It's sure.
Now, for the tech side of the detective work, we have CT scans, MRIs, lumbar punctures. What is the absolute go-to for an emergency?
A non-contrast CT scan of the head. Hands down, every time.
Why non-contrast?
Because it's fast. The scan takes about 30 seconds, and it is exceptionally good at showing fresh blood.
Which is what you're looking for in trauma or a stroke.
Exactly. Fresh blood lights up bright white on a CT scan. So if someone comes in with stroke symptoms or a head injury, they go straight to the CT scanner to rule out a bleed.
Why not use an MRI first? Isn't an MRI much more detailed?
It is much more detailed, but it takes 45 minutes to an hour to do a brain MRI, and the patient has to lie perfectly still inside a giant, loud magnet.
And an unstable, vomiting trauma patient can't do that.
They can't. Plus, remember the golden rule. Time equals brain. You do not have 45 minutes to wait for an image when brain tissue is dying.
So MRI is for later.
Yes. MRI is fantastic for things that aren't acute emergencies, looking for brain tumors, spotting the plaques of multiple sclerosis, or looking at spinal cord injuries.
Okay, that makes sense. Now, I noticed a huge bolded warning in the source notes regarding lumbar punctures, spinal taps.
Yes, critical safety rule.
The notes say, do not do an LP if there are signs of increased intracranial pressure, which honestly feels a little counterintuitive to me. Wouldn't draining some spinal fluid from the back help layer the pressure in the head?
I see why you'd think that, but doing that is a deadly trap.
Really?
Think about the physics of the closed system.
Yeah.
You have extremely high pressure up in the skull, and you have lower pressure down in the spinal canal.
Okay.
If you stick a needle in the lower back and drain fluid out, you create a vacuum, a sudden low-pressure zone at the bottom.
Oh, no.
Yes. The extreme high pressure in the head will instantly slam the brainstem down into that vacuum. It pulls the brain through the foramen magnum.
And causes instant herniation.
Instant herniation and death, yes.
Oh.
So the absolute rule in neurology is you always get a CT scan of the head first to guarantee there is no massive swelling or a tumor before you ever stick a needle in someone's back.
That is a crucial tip. Scan before you tap.
Always.
All right, let's shift into segment 3. Under pressure, we are diving deep into neurological trauma and TBI.
Let's do it.
We need to revisit that closed box concept. The fancy name for it in the notes is the Monroe-Kelly hypothesis.
Right. It sounds complex, but it's just basic volume dynamics. The skull is a rigid container. Inside that container, there is a fixed volume shared by exactly 3 things.
Brain tissue, blood, and cerebrospinal fluid.
Yes. Brain tissue takes up about 80%, blood takes up 10%, and the CSF takes up the last 10%.
And because the box is bone, it does not stretch.
It does not give a single millimeter. So if one of those 3 components gets bigger, say the brain tissue swells up, or if you add a completely new 4th component like a bleeding blood clot, something else has to be kicked out of the box to make room.
So what leaves first? What gets evicted?
The body's first line of defense is to shunt the CSF down into the spinal cord out of the head. Then it tries to squeeze the venous blood out faster.
That's the compensation phase.
Exactly. But there's only so much fluid you can squeeze out. Once that extra space is used up, the compensation fails.
And the pressure skyrockets.
It shoots up vertically on the graph. It's not a gradual increase. It's a sudden, catastrophic spike.
Let's look at some of the specific injuries that cause this. Skull fractures. Sometimes they're obvious, like a depressed fracture, where the bone is caved in.
Right.
But the notes specifically mention basilar skull fractures, fractures at the very base of the skull. These seem really tricky because you can't actually see the crack.
You usually can't see the fracture itself, even on some x-rays, but you can see the evidence of the leak it causes.
What kind of evidence?
We look for specific bruising patterns. The first is raccoon eyes.
Bruising around both eyes.
Dark purple bruising around both eyes, yes.
Yeah.
Then there is battle sign.
Battle sign. Where is that?
It's bruising right behind the ear, over the mastoid bone. It looks like they got hit behind the ear.
And then there is the halo sign, which involves the actual spinal fluid, right?
Right. When the base of the skull cracks, the membrane holding the CSF tears, so fluid starts leaking out of the nose. That's rhinorrhea, or out of the ear, otorrhea.
But how do you know if it's CSF and not just a runny nose or blood?
You do the halo test. You let a drop of that fluid fall onto a piece of gauze. Because CSF has sugar and protein in it, it separates from blood.
Like oil and water.
Kind of. The blood cells are heavy, so they stay in a red dot right in the middle of the gauze. But the clear CSF spreads out further, creating a yellowish ring around the blood.
A halo.
Exactly. If you see that halo, it confirms that the barrier to the brain is broken.
Which means the brain is open to the outside world?
Which means a massive risk for infection, meningitis. And there is a major nursing rule here that the sources emphasize.
What's the rule?
If you see signs of a basilar skull, fracture raccoon eyes, leaking fluid, you absolutely never put a tube up the patient's nose. No nasogastric tubes.
Because it could go through the fracture.
It happens. The tube goes up the nose, hits the shattered cribriform plate at the base of the skull, slides right through the crack, and ends up coiled inside the patient's frontal lobe.
That is horrific.
It's a fatal mistake. If they have a base fracture, you always route tubes through the mouth instead. Orogastric.
Okay, duly noted. Let's talk about hematomas next. Collections of blood inside the skull. We need to distinguish between an epidural hematoma, a subdural, and an intracerebral.
They behave very differently.
Let's start with epidural. The notes describe a very specific, almost cinematic presentation for this, the lucid interval.
Yes. This is known in trauma bays as the talk and die scenario.
Talk and die.
It's usually caused by a sharp blow to the side of the head, right over the temple, like getting hit with a baseball or a hockey puck.
Because the bone is thin there.
Thin bone, and right underneath it runs the middle meningeal artery. The bone breaks and slices that artery.
And arteries bleed fast.
Very fast, and under high pressure. But initially, the impact knocks the person out. A few minutes later, they wake up.
And they seem okay?
They feel completely fine. They're talking to you, answering questions. They might even try to refuse medical care and say they want to go home.
That is the lucid interval.
Yes. But inside their skull, that artery is pumping blood, expanding the hematoma rapidly. The pressure is building.
And then what happens?
Suddenly, the compensation limit is reached. They crash. They lose consciousness, their pupil blows, and they herniate.
Oh.
If you catch them during that lucid interval and rush them to the OR to drill a hole and drain the blood, they usually survive with no deficits. If you let them go home to sleep it off, they die in their bed.
That is incredibly deceptive. What about the subdural hematoma? How is that different?
Subdural bleeds are usually venous. They come from the tiny bridging veins that connect the brain to the dura mater.
And veins bleed slower than arteries.
Much slower. It's a slow ooze. This is incredibly common in the elderly population or in chronic alcoholics.
Why those two groups?
Because as we age, or with heavy alcohol use, the brain actually shrinks a little bit. It's called atrophy.
Okay.
When the brain shrinks, it pulls away from the skull, which stretches those little bridging veins tight like guitar strings.
So it takes less force to snap them.
Exactly. A very minor bump to the head, something they might not even remember happening, can tear a vein.
And because it's a slow venous ooze, the symptoms take a while to show up.
It can take days or even weeks for enough blood to accumulate to cause pressure.
So Grandpa falls, seems fine, but 2 weeks later he starts acting confused or his balance is off.
Exactly. And people often mistake it for a sudden onset of dementia or a stroke, but it's actually a slow-growing subdural hematoma.
And the third type, intracerebral hemorrhage.
That is bleeding deep inside the actual meat of the brain tissue. It's not on the surface.
What causes that? Trauma.
Sometimes trauma, but very often it's driven by severe, uncontrolled hypertension. A weakened blood vessel deep in the brain just bursts under the high blood pressure.
Is that treatable with surgery?
It's extremely difficult. Because the bleed is deep inside, a surgeon would have to cut through healthy, functioning brain tissue just to reach the clot. So management is often focused on controlling the pressure medically.
Which brings us to the interventions. How do we actually manage this intracranial pressure in the ICU? What do the nurses do to keep that closed box from exploding?
A lot of it comes down to facilitating drainage. using physics to our advantage.
Physics like gravity.
Exactly. Positioning is key. We keep the head of the bed elevated at exactly 30 degrees. This uses gravity to help drain the venous blood out of the head and back to the heart.
Too flat is bad, but is sitting them straight up bad too?
Sitting straight up at 90 degrees can actually pinch off the veins in the hip and increase abdominal pressure, which strangely translates up to the head. So 30 degrees is the sweet spot.
And the notes mention keeping the head midline.
Yes, keep a nose aligned with the navel. If the patient's head is turned hard to the left or right, it kinks the jugular vein in the neck.
Like kinking a garden hose.
Exactly. The blood can get into the head through the arteries, but it can't drain out through the kinked vein. So the ICP rises. It's such a simple physical fix, just straighten their head.
What about managing the ventilator? There's a section here on carbon dioxide management.
CO2 is a very potent vasodilator in the brain.
Meaning it opens the blood vessels up.
Right. If you have too much carbon dioxide in your blood, the brain's vessels open wide and become engorged. That extra blood volume takes up space in the skull,
which raises the pressure.
So we might tweak the ventilator settings to increase the patient's respiratory rate, helping them blow off more CO2. We actually want them slightly hyperventilated to cause mild vasoconstriction.
It shrinks the vessels to create more room in the box.
Precisely.
And what about medications? The big one listed here is mannitol.
Mannitol is our heavy artillery. It's an osmotic diuretic.
How does it work?
Think of it as a chemical sponge for water. It's a heavy sugar molecule. You push it into the IV, it goes into the bloodstream, and because it's highly osmotic, it literally pulls fluid out of the swollen brain tissue and into the blood vessels.
That sucks the edema dry.
It dehydrates the brain tissue to reduce the swelling, and then the kidneys filter it out and the patient pees out the extra fluid.
That's brilliant.
It's very effective for rapid pressure reduction.
Okay, shifting gears from trauma to another type of space-occupying problem. Segment 4. Unwanted guests. Oncologic disorders.
Brain tumors.
Yes. And based on what we just learned about the closed box, a tumor in the brain is uniquely dangerous compared to a tumor in, say, the liver.
Exactly. Because there is no extra room. Even a completely benign tumor is life-threatening in the skull.
Because of the mass effect.
Right. A benign meningioma that grows slowly and doesn't spread can still press against the brainstem and stop you from breathing. The location is just as important as the malignancy.
The notes mention a very specific symptom pattern to watch out for with brain tumors. The morning headache. Why is it worse in the morning?
It goes back to gravity and breathing. When you lie flat to sleep at night, the venous drainage from your brain naturally slows down a little bit.
Because you aren't upright.
Right. And your breathing also slows down when you sleep, which means your carbon dioxide levels rise slightly.
Which dilates the vessels.
Exactly. So in a healthy person, this causes a tiny, unnoticeable increase in intracranial pressure overnight.
But if you have a tumor...
If you have a tumor already taking up all the spare room, that slight nocturnal rise is enough to push the pressure into the pain zone.
So you wake up with a pounding headache.
A pounding headache that magically gets better after you've been standing upright and breathing normally for an hour or two, that is a massive red flag.
That is such a fascinating diagnostic clue. Now, there is a critical emergency listed in this section involving tumors, spinal cord compression.
Yes, this is often metastatic, meaning the cancer started somewhere else, like breast, lung, or prostate cancer, and it spread to the bones of the spine.
And the tumor grows inward.
It grows right into the spinal canal and crushes the spinal cord.
What are the early signs of that?
If a patient with a known history of cancer complains of severe new onset back pain, especially if it's pain that gets worse when they lie flat on their back, you have to listen.
And what if it progresses past just pain?
If they start having radiating pain down the legs, or weakness or numbness, that is the final alarm bell.
What's the late sign?
Loss of bowel or bladder control. If you wait for that to happen, it is usually too late. The paralysis often becomes permanent at that point.
So what's the immediate action?
Immediate MRI of the spine, and we blast them with high-dose corticosteroids, usually dexamethasone.
To shrink the swelling.
Yes, to quickly shrink the edema around the tumor, to take the pressure off the cord while we prep them for emergency radiation or surgery. It's a race against the clock to save their ability to walk.
Wow. Okay, segment 5. Short circuits, seizures and epilepsy.
This is a big one.
We really need to clear up some myths here.
Mm.
First and foremost, the whole putting a spoon in the mouth thing.
Please, everyone listening to this, forget you ever saw that on TV. Do not ever put a spoon, a wallet, a tongue depressor, or your fingers into a seizing patient's mouth.
The old myth is that they're going to swallow their tongue.
Right, which is anatomically impossible. Your tongue is anchored to the floor of your mouth. You cannot swallow it.
So what happens if you shove something in there?
You will break their teeth. That broken tooth will fall to the back of the throat and block their airway. Or you will cause bleeding that they choke on. Or, very likely, they will clamp down with incredible jaw force and bite your finger clean off.
Do not put anything in the mouth. Got it.
Yeah.
So what do you actually do when someone has a grand mal seizure?
You focus purely on safety and time.
Safety meaning moving furniture away.
Move the chairs, put something soft under their head, and as soon as you can, gently roll them onto their side.
Why the side?
So if they vomit or if they have excess saliva, gravity will pull it out of their mouth onto the floor. If they're flat on their back, it goes straight down into their lungs.
Aspiration.
Exactly.
You mentioned time.
Look at your watch immediately. You have to time the seizure. Most seizures are self-limiting. They stop on their own in 1 to 2 minutes.
The brain just kind of tires itself out.
Yes, the electrical storm runs out of energy, but if it goes past 5 minutes, or if they have repeated seizures back-to-back without waking up in between, that is a completely different beast.
That's what the notes call status epilepticus.
Status epilepticus. It is a profound medical emergency.
What's happening in the brain during that?
The brain is redlining. It's firing so fast and so hard that it is burning through oxygen and glucose faster than the bloodstream can possibly deliver it.
So the brain is starving itself to death.
Literally. The neurons begin to die from pure metabolic exhaustion. If you don't stop the seizure, they will suffer permanent brain damage or cardiac arrest.
So at the 5-minute mark, it's a code blue. What is the drug protocol to stop it?
We need to shut down the electrical storm immediately. The first line of defense is benzodiazepines.
Like lorazepam or diazepam?
Right, Ativan or Valium. We push it 5E. These drugs act as the brakes for the brain. They suppress the central nervous system and stop the shaking very fast.
But they wear off quickly, don't they?
They do. So the moment the shaking stops, you have to follow up immediately with a loading dose of a long-acting anti-epileptic drug.
Like fosphenytoin or levetiracetam?
Keppra.
Exactly.
Yeah.
The benzos stop the current fire. The Keppra prevents it from reigniting an hour later.
Benzos to stop, Keppra to hold. Makes sense. Let's touch on meningitis here, since it affects the meninges, the lining of the brain. The notes specify that bacterial meningitis is a dire emergency.
It kills incredibly fast. A patient can go from a slight headache to dead in a matter of hours.
We're looking for the classic triad of symptoms, right?
Yes. High fever, a severe headache, and neutral rigidity.
Neutral rigidity, that's the stiff neck.
Right. They physically cannot touch their chin down to their chest because the inflamed meninges in the spine stretch and cause excruciating pain.
And photophobia is common too.
Yes. Bright lights actually hurt their eyes.
What about the rash? I've heard there's a specific rash.
If the infection is caused by the meningococcal bacteria, you will often see a petechial rash. Little red or dark purple pinprick spots on the trunk or legs. And if you press on them,
they don't fade or blanch when you press a glass against them. That rash indicates that the bacteria is in the bloodstream, causing sepsis and microbleeding into the skin.
What is a golden rule for treatment in the ER?
Isolate and medicate.
Isolate first.
Immediately put them on droplet precautions. Everyone entering the room wears a mask. It's highly contagious.
And then?
You draw blood cultures and you hang broad-spectrum IV antibiotics immediately.
Do you wait for the CT scan or the spinal tap results first?
Absolutely not. Do not wait for the CT scan. Do not wait for the lumbar puncture. If you suspect bacterial meningitis, every minute of delay increases the risk of permanent brain damage or death. Treat first, confirm later.
Treat first, confirm later. That's a great rule. All right, segment 6, wiring and degeneration.
The chronic disorders.
Yeah, we have a lake of chronic neurologic disorders here. These are incredibly complex diseases, so let's try to capture the big idea or the specific mechanism for each one. Let's start with multiple sclerosis, or MS.
MS is a demyelinating disease. It's an autoimmune condition where the body's own immune system attacks the myelin sheath.
The insulation on the wires.
Exactly. The myelin wraps around the nerves in the central nervous system. Think of a power cord. If you strip the rubber insulation off, the electrical signal sparks out, it slows down, or it gets completely blocked.
So the signals from the brain just don't make it to the muscles cleanly.
Right. And because these lesions can happen anywhere in the brain or the spinal cord, the symptoms are entirely unpredictable. One patient might have vision loss, another might have numb legs, another has severe fatigue.
The notes highlight a specific trigger for MS symptoms: heat.
Yes, Uthoff's phenomenon. Heat slows down electrical conduction in damaged nerves. So taking a hot shower, or sitting in a hot tub, or even getting a fever can trigger a temporary but severe flare-up of their MS symptoms.
Okay. Then we have myasthenia gravis, or MG. This one isn't an issue with the wire itself, right? It's the plug.
That's a great analogy. It's an attack on the neuromuscular junction. The nerve sends the electrical signal just fine, but the receptors on the muscle side are blocked or destroyed by antibodies.
So the muscle just doesn't get the memo to move.
Right. And the absolute hallmark of MG is fatigability.
Meaning they get weaker as the day goes on.
Exactly. When they wake up in the morning after resting, their muscles are relatively strong, but as they use them throughout the day, the few working receptors get depleted.
So by dinner time.
By evening, their eyelids droop heavily. That's called pertosis. They might have double vision. And most dangerously, they might have trouble chewing and swallowing their food.
Which leads to the major emergency, myasthenic crisis.
Yes. That's when the weakness hits the diaphragm and the intercostal muscles. They simply become too weak to pull air into their own lungs. They require mechanical ventilation.
How is MG treated day to day?
With drugs called cholinesterase inhibitors, like pyridostigmine, these medications basically flood the junction with acetylcholine to help the signal force its way across the gap.
And timing of that medication is critical. Right.
You must give the medication 30 to 45 minutes before meals. It peaks right when they eat, giving them the maximum muscle strength to chew and swallow safely without choking.
Perfect timing is everything. Okay, next up is Guillain-Barré syndrome, GBS. This one is bizarre because of how it moves.
Ascending paralysis, it's a hallmark.
Ascending meaning it starts low and goes high.
Yes. It usually develops a few weeks after a mild viral infection, like a respiratory bug or a stomach flu. The immune system gets confused and starts attacking the peripheral nerves.
Starting at the bottom.
It starts in the toes and feet. Tingling, numbness, weakness. Then over a few days, it moves up to the legs, then the hips, and then the torso. It literally climbs up the body like rising water.
And the terror is when the water level reaches the chest.
Exactly. When the paralysis hits the respiratory muscles, they stop breathing. So in the hospital, our priority is constant monitoring of their vital capacity.
Measuring how big of a breath they can take.
Right. We use a spirometer. If that volume starts dropping, we don't wait for them to turn blue. We intubate them electively before they crash.
The silver lining with GBS, though, is that it's usually temporary.
Yes. Unlike MS or ALS, the peripheral nerves can actually regenerate. The paralysis peaks, plateaus, and then slowly descends back down. They usually recover, but it can take months of rehab.
Let's talk about Parkinson's disease.
This is a disease of dopamine depletion in the basal ganglia of the brain.
Dopamine is a neurotransmitter.
Right. Think of dopamine as the motor oil in the engine that allows for smooth, coordinated movement. Without enough dopamine, the gears grind.
Which causes the physical symptoms.
You see the classic triad: resting tremors, their hands shake when they aren't doing anything, rigidity, their muscles are constantly stiff, and bradykinesia, incredibly slow, deliberate movement.
They often have that shuffling walk, right?
A shuffling gait, and they lose natural facial expressions, giving them a mask-like face. So for nursing care, safety is paramount. Fall prevention is huge, and taking aspiration precautions while eating because swallowing becomes difficult.
Let's quickly contrast Alzheimer's disease and delirium because they both involve confusion, but they are very different.
Very different. Alzheimer's is a chronic, progressive, irreversible degeneration of the brain. The physical structure of the brain changes over years.
They need safety, routine, and a calm environment.
Right. Now, delirium is acute. It happens suddenly. It fluctuates throughout the day.
And it's usually caused by an outside factor.
Exactly. It's often entirely reversible. A severe urinary tract infection in an elderly patient can cause profound delirium, or an adverse reaction to a new medication or hypoxia. You find the underlying cause, fix it, and the confusion clears up.
So Alzheimer's is structural, delirium is chemical or situational.
That's a great way to summarize it.
Okay, ALS, amyotrophic lateral sclerosis, Lou Gehrig's disease.
This one is incredibly heavy. It is a rapid degeneration of the motor neurons in the brain and spinal cord. The brain simply loses the ability to send signals to the voluntary muscles.
So the muscles waste away.
Severe atrophy. But, and this is the uniquely cruel part of ALS, the sensory nerves and the cognitive function usually remain completely intact.
So they can feel everything and their mind is sharp.
The patient is fully aware, fully intelligent, but slowly trapped in a body that refuses to move. Eventually, it leads to locked-in syndrome, where they can only communicate by blinking.
The focus must shift heavily to respiratory support and communication devices.
Yeah.
Let's end this segment with Bell palsy.
Unilateral facial paralysis. It's caused by inflammation of cranial nerve 7, the facial nerve.
It looks exactly like a stroke, though. Half the face suddenly droops.
It terrifies people, naturally. But there is a very quick physical test to tell the difference between Bell palsy and a stroke.
What's the test?
You ask the patient to raise their eyebrows or wrinkle their forehead. In a stroke, the forehead is usually spared. They can still raise both eyebrows perfectly fine, even though the bottom half of their face is drooping. That's because the upper face has dual wiring from both sides of the brain.
Oh, interesting. And in Bell palsy.
Because Bell palsy is damage to the nerve right as it exits the skull, the entire half of the face is paralyzed, top to bottom. They cannot raise the eyebrow on the affected side.
That is a brilliant diagnostic trick. What is the main nursing care for Bell palsy?
Protecting the eye. Because they physically cannot close their eyelid, the cornea is exposed to the air 24/7. It can dry out, ulcerate, and cause permanent blindness. They need artificial tears constantly, and they must tape the eye shut or wear an eye patch at night.
Segment 7. Blockages. Cerebrovascular disorders, otherwise known as stroke.
We are right back to time equals brain.
We all know the public health acronym FAST.
Right.
Face drooping, arm weakness, speech difficulty, time to call 911.
It's a great campaign. It catches the big signs.
But medically, we need to talk about the two different types of stroke, because the treatment for one will kill the patient if they have the other.
Yes, ischemic versus hemorrhagic.
Break those down.
An ischemic stroke is a plumbing issue. A blood clot forms or travels to the brain and blocks a blood vessel. The brain tissue downstream starves. This accounts for about 87% of all strokes.
It's a blockage. And hemorrhagic.
Hemorrhagic is a rupture. A weakened blood vessel bursts open and bleeds directly into the brain tissue.
And you can't tell the difference just by looking at the patient in the ER.
You absolutely cannot. They present with the exact same symptoms: weakness, slurred speech, facial droop.
Which is why the CT scan is the ultimate gatekeeper.
The non-contrast CT scan is the only way to know. You rush them to the scanner. If the scan is clear, no bright white spots of blood, you assume it's an ischemic stroke.
And if it's ischemic, you have a very specific window for treatment.
Yes. If you can confirm the exact time their symptoms started, and it has been less than 3 to 4.5 hours, you can administer thrombolytics, TPA.
The clot buster drug.
It's a powerful systemic enzyme that hunts down and dissolves the blood clot, restoring flow. It's basically a miracle drug when given in time.
But it carries a massive risk of bleeding.
A massive risk, which is exactly why you never, ever give it until the CT scan rules out a hemorrhagic stroke. If you give a clot-busting blood thinner to someone who is already bleeding into their brain,
that would be like pouring gasoline on a fire.
It is invariably fatal. For a hemorrhagic stroke, you completely avoid anticoagulants. You focus entirely on bringing down their blood pressure to slow the bleeding and managing the intracranial pressure.
What about a TIA? The mini stroke.
I really strongly dislike the term mini stroke. It gives patients a false sense of security. A transient ischemic attack, or TIA, is a warning shot across the bow.
What's the difference between a TIA and a full stroke?
In a TIA, a small clot blocks the vessel, the symptoms start, the arm goes numb, the speech slurs, but then the body's own natural clot-busting enzymes manage to dissolve the clot quickly, before any permanent cell death occurs.
So the symptoms completely resolve on their own in a few minutes or an hour.
Exactly. And because they feel fine again, people think, oh, I'm fine, it passed.
But they aren't fine.
No, that was a warning. A massive percentage of people who suffer a TIA will go on to have a catastrophic major stroke within the next few days or weeks. The underlying problem is still there.
So if you have a TIA, you need a full cardiac and neuro workup immediately.
Immediately. You have to find where that clot came from. Do they have atrial fibrillation in the heart? Do they have plaque blocking their carotid artery? You find the source and fix it before the big one hits.
Okay, we are moving into the sensory systems. Segment 8, the sensors. Starting with eye and vision disorders.
Vision is so critical for a patient's independence and safety, but these disorders can really sneak up on you.
Let's contrast the two types of glaucoma, open angle and angle closure.
Glaucoma fundamentally is a disease of elevated intraocular pressure, high pressure inside the eyeball that slowly crushes the optic nerve at the back.
Okay, so open angle is the common one.
Right, yes. It's often called the silent thief of sight. It is incredibly slow. The tiny drainage channels in the eye just get sluggish and clogged over years and years. The fluid builds up and the pressure rises very slowly.
And it's painless.
Completely painless. And you lose your peripheral vision first, so your brain kind of compensates. You develop tunnel vision without realizing it until one day you start bumping into door frames and realize you can't see to the sides.
Wow. Versus angle closure glaucoma.
That is an acute, blinding emergency.
Yeah.
The drainage angle between the iris and the cornea snaps shut completely and abruptly. The pressure inside the eye spikes instantly.
What does the patient feel?
The symptoms are highly dramatic. Excruciating, severe eye pain, a rock-hard eyeball, nausea and vomiting from the pain, and they see bright halos around lights.
What's the treatment?
Immediate drops to constrict the pupil, to pull the iris away from the drain, and IV medications to drastically lower the pressure. If you don't treat it in hours, the optic nerve dies and they go permanently blind in that eye.
Retinal detachment is another emergency listed here.
Yes, the curtain.
The curtain.
The retina is the light-sensitive wallpaper on the back of the eye. Sometimes it tears and fluid gets under it, peeling it off the back wall.
Like wet wallpaper.
Exactly. Patients usually describe a sudden onset of flashes of light photoxia and a massive swarm of floaters, like black spots or cobwebs in their vision.
And then the curtain.
Then they literally see a dark shadow or a curtain coming down over their field of vision. This is a surgical emergency. The retina has to be lasered or frozen back into place.
What do you do while waiting for surgery?
Keep the patient incredibly still, both eyes patched to prevent rapid eye movement, because moving the eye can cause the tear to unzip further.
Just a quick note on cataracts and macular degeneration before we hit the ears.
Cataracts are simply the clear lens of the eye becoming cloudy and opaque with age. It causes blurry, hazy vision. The fix is a routine surgery to replace the lens.
And the post-op care.
Super important. You must teach the patient to avoid doing anything that increases pressure in the head or eye. No heavy lifting, no straining on the toilet, no bending completely over to tie shoes.
Got it. And macular degeneration.
That is the exact opposite of open-angle glaucoma. Glaucoma steals the peripheral vision. Macular degeneration destroys the macula, the center of the retina. So they lose their central high-resolution vision. They can see the edges of a clock, but they can't see the hands in the middle.
That sounds incredibly frustrating.
It's the leading cause of severe vision loss in older adults.
Let's finish up the medical content with segment 9. Sound and balance. Hearing disorders.
The ears are complex little organs.
Meniere's disease. This sounds miserable.
It is truly debilitating for some people. It's a disorder of the fluid balance deep inside the inner ear. It presents as a very specific triad of symptoms.
What's the triad?
Episodic vertigo, which is the sensation that the room is spinning violently. Tinnitus, which is a loud ringing or roaring in the ear. And progressive hearing loss.
The spinning sounds awful.
The vertigo attacks can be so severe that the patient can't stand up. They just lie on the floor and vomit. Fall precautions in the hospital are absolutely essential during an attack.
Is there a cure?
No cure, but we try to manage the fluid buildup. The most effective lifestyle change is a strictly low-sodium diet.
Why does salt matter for the ear?
Because salt holds water. If you eat a big bag of salty potato chips, your entire body retains fluid, including that tiny compartment in the inner ear. That sudden extra fluid pressure triggers the vertigo attack.
That makes total physiological sense. One last point from the sources. Ototoxicity. We have to be really careful with the drugs we administer.
We do. Several very common hospital drugs are toxic to the acoustic nerve in the ear.
Which ones?
Aminoglycoside antibiotics are major offenders, like gentamicin or vancomycin, also very high doses of aspirin and certain chemotherapy drugs.
How do you know if it's happening?
The patient will tell you. If a patient on IV gentamicin suddenly says, "Hey, my ears are ringing constantly," you must pay attention.
Tinnitus is the first sign.
It is the early warning system of ototoxicity. Stop the infusion, draw blood levels, and call the provider. If you catch it right at the ringing stage, the hearing loss might be reversible. If you ignore it and keep giving the drug, you will permanently deafen your patient.
Wow.
Yeah.
We have covered a truly massive amount of ground today.
We really have, from the physics of the skull to the fluid in the inner ear.
So if you had to synthesize all of this for the listener, what is the common thread running through all these neurological topics?
I think it comes back to the incredible fragility of the system. The human nervous system is arguably the most powerful computer in the known universe, but it is incredibly high maintenance.
It demands perfection.
It requires a perfectly controlled environment. It needs exact pressure, that CPP. It needs a constant, uninterrupted supply of high-octane fuel oxygen and glucose. It needs clear plumbing to drain the spinal fluid.
And when things go wrong,
Whether it's a tumor slowly pressing on it, or a sudden blood clot starving it, or a blunt trauma making it swell, the mechanism of injury is almost always a disruption of that delicate, closed environment.
and for the listener, whether they are a nursing student, a medic, or just someone taking care of their aging parents, why does deeply understanding this matter?
Because you are the first line of defense. The machines can't catch the earliest signs.
Right.
You are the one who notices that your partner's smile looks just a tiny bit asymmetrical. You are the one who notices that grandma is slightly more confused today, 2 weeks after she bumped her head on the cabinet.
You're the one who hears complain about the worst sudden headache of their entire life.
Exactly. Recognizing those subtle early signs, recognizing that the grace period is non-existent when it comes to the brain, that is what saves lives.
Time equals brain.
Time equals brain, always.
I want to leave you with a final thought today. We spent an hour talking about how vulnerable the brain is, how 4 minutes without oxygen, and it's basically game over. But think about the extreme paradox of neuroplasticity. We see massive trauma, strokes that wipe out entire speech centers, and yet, with time and grueling therapy, we see patients rewire their own brains.
They build entirely new neural pathways around the dead tissue.
They learn to walk again, they learn to speak again. It is this profound paradox. The nervous system is simultaneously the most fragile, vulnerable organ in the human body and the most adaptable, resilient thing in nature.
It's beautiful, really.
It is. So take care of it. Wear a helmet, manage your blood pressure, and keep learning. Stay curious.
Absolutely. See you next time.